Hey guys, Joel here with the Shift Brief. On today's episode, we're going to talk about waveform capnography. We're going to look at how CO2 is made, how it moves through the body, and how it's eliminated. Not only is waveform capnography the gold standard for intubation confirmation, but it's widely applicable in multiple other settings. So let's get going and dig into it a little bit. So let's start with a question. If I took away your ability to monitor everything in your ambulance, but left you to choose only one thing to keep, what would you keep? Most people would say the ECG. Other people might say blood pressure or SATs, maybe even blood glucose. My personal choice would be to keep waveform capnography. And the reason why is because capnography gives us information about ventilation, circulation, metabolism, and airway, all in a single monitor, and it is updated literally with every breath. So let's start with the basics. Capnography measures carbon dioxide in exhaled air. There's really two terms that you'll hear. Capnometry is simply the number. It's the end-tidal carbon dioxide, or EtCO2. Capnography is the number plus the waveform. If you look at it like a story, the number, or capnometry, will tell you what happened. The waveform, or capnography, tells you why. In pre-hospital medicine, the why is usually the most valuable piece of information. To understand capnography, first we need to understand where CO2 or carbon dioxide comes from. Every cell in the body produces CO2 as a waste product of cellular metabolism. That CO2 diffuses into the bloodstream, and then it ultimately is transported to the lungs. The heart pumps that blood through the pulmonary circulation. Finally, the lungs eliminate the CO2 during exhalation. That means there are four major components involved. Metabolism produces CO2, perfusion transports it, ventilation removes it, and then, of course, the airway allows the gas to escape. If any one of these systems fails, then the capnogram will change. And that's why capnography is much more than just a ventilation monitor. A normal end-tidal CO2 ranges between 35 and 45 millimeters of mercury, and that's the amount of carbon dioxide at the end of exhalation. Now, if we look at the waveform, a normal capnogram has four phases. Phase 1, it's kind of at the bottom, it's dead space ventilation. This is the air sitting in the conducting airways, the trachea, the bronchi. Since no gas exchange occurs there, then there's essentially no carbon dioxide, so the waveform remains flat along the baseline. Phase 2 is the expiratory upstroke. As alveolar gas begins mixing with dead space gas, carbon dioxide rapidly rises. You can think of this as kind of opening the door between fresh air and used air. Phase 3 is called the alveolar plateau. Now we're mostly exhaling alveolar gas. This portion should be relatively flat. The highest point at the end of this plateau is your end-tidal CO2 measurement. And then finally comes inspiration. Fresh gas enters the lungs, carbon dioxide immediately drops back to zero, and the cycle begins all over again. A normal capnogram looks almost like a square wave. When that square changes shape, your patient is trying to tell you something. Whenever you look at capnography, you should really ask yourself four questions. First, is there a waveform? If there isn't, then you need to think about things like apnea, esophageal intubation, maybe a disconnected circuit, equipment failure, or even cardiac arrest. Second, is the waveform the right shape? The morphology is often more important than just the actual number. Third, what about the end-tidal value? Is it normal? Is it high, low? And then finally, ask whether or not the trend is changing. A single number is only a snapshot. Trending it is what actually tells the story. Now let's talk about elevated end-tidal CO2. High readings typically mean one of two things. Either the patient is producing more carbon dioxide, or they're not eliminating it. Hypoventilation from opioids, sedatives, fatigue, that can all cause carbon dioxide retention. Asthma and COPD can also elevate end-tidal CO2 because patients struggle to exhale effectively. Now let's talk about low end-tidal CO2. Low values can occur because your patient is blowing off too much carbon dioxide, such as during anxiety or pain-induced hyperventilation. But low end-tidal CO2 can also mean something much more dangerous. If blood isn't actually reaching the lungs, then CO2 can't be delivered for exhalation. That means severe shock, PE, cardiac arrest, or even massive hemorrhage can produce a low end-tidal CO2. This is why capnography is such an excellent perfusion monitor. One of the most recognizable capnography waveforms is the shark fin. So you can imagine a patient having a severe asthma attack. Instead of a rapid rise and flat plateau, expiration becomes prolonged. So that means the upstroke becomes slanted. The plateau slopes upward instead of remaining flat. The waveform literally looks like a shark's fin. Well, why is that? It's because bronchospasm narrows the airways. Air escapes slowly instead of quickly. You get some gas trapping. The worse the bronchospasm becomes, the larger the shark fin becomes. As bronchodilators work, so you're giving your patient Atrovent Ventolin, you'll actually watch the waveform become much more square. That's one of the few monitors that lets you actually watch treatment working in real time. Now let's imagine that your waveform just completely disappears. What's the first thing that you're thinking? Well, you shouldn't be blaming the monitor first. Make sure that you assess your patient. If they're intubated, make sure the tube hasn't become dislodged. Check the ventilator tubing, make sure it's connected. If your patient was breathing spontaneously, are they now apneic? Or has circulation stopped? Are they in cardiac arrest? Treat the patient, not the monitor. We've all heard that a million times. Now let's discuss one of capnography's most valuable applications, cardiac arrest. During CPR, end-tidal CO2 reflects pulmonary blood flow. Good chest compressions generate better blood flow, which means more CO2 is actually going to reach the lungs. Higher end-tidal CO2 generally indicates better quality CPR. But if your end-tidal suddenly jumps from 12 to, let's say, 40, don't just celebrate. Check for a pulse. That sudden rise is often one of the earliest indicators of ROSC. Sometimes capnography tells you ROSC has occurred before you can even feel the pulse. Capnography is also the gold standard, as I said before, for confirming ET tube placement. Seeing a continuous waveform over multiple breaths confirms that carbon dioxide is coming from the lungs. In my practice, in the service that I work for, we use that terminology all the time. It's sustained waveform, not just a single wave, it is sustained. We see them every breath. An ET tube that is placed in the esophagus, well, it might produce a few small waveforms initially, but then they quickly disappear. Sustained waveform means you're in the trachea. If you don't have sustained waveform, you should immediately be concerned. All right, let's finish this up with a few cases. So, first patient, let's say, is a 68-year-old with severe COPD. They're wheezing, speaking, 1 to 2 word sentences, and their end-tidal is showing 60. The waveform has that classic shark fin appearance. What is that trying to tell you? Well, it is severe bronchospasm with inadequate exhalation. You're going to give them some bronchodilators, and that should gradually return that waveform towards a square shape. Case 2. You're performing CPR. The end-tidal has been around 10 for several minutes, and suddenly it rises to 47. What should you do? Well, finish your 2 minutes of CPR and then assess for a pulse. That sudden rise in end-tidal CO2 strongly suggests that ROSC has been achieved. Case 3. An intubated trauma patient, they suddenly lose their waveform. So is it a monitor problem? No. Let's make sure that we're assessing the patient. Look at the tube. check the circuit, evaluate the pulse. Always trust your assessment before you're just going to jump to blaming the equipment. It's part of the process for sure, but make sure that you're assessing your patient first. Guys, thanks for taking the time to watch this video on Waveform Capnography. Make sure that you like, share, and subscribe to my YouTube channel, and stay tuned for more. Thanks again.